Hello, everyone, and welcome to the International Interprofessional Mentorship Meeting. I am Dr. Kate Barlow, the founder of the program and your host for today's meeting. It's June 9th, 2021, and today Dr. Patty Coker-Ball is here to talk about promoting evidence-based pediatric CIMT abroad cases from Vietnam and Ethiopia. Please mute yourselves during the presentation and unmute yourself whenever you would like to ask a question. You can also type your questions into the chat box and I will ask the questions for you. In order to receive a certificate of attendance, please enter your name and email into the chat box now, and you'll need to remain on the webinar until the presenter is finished. At the conclusion of the presentation, we will have an optional meet and greet. Thank you all for coming today, and let's get started. Thank you so much, Patty, for coming.
Well, it's wonderful to be invited. I appreciate that, Kate. It is definitely a subject I love to talk about, and I really do want to encourage people that are on this Zoom to ask questions, and I will answer them the best I can and provide any resources that you might find helpful. So as Kate said, I am going to talk to you about some experiences working with wonderful practitioners in other countries providing constraint-induced movement therapy in pediatric settings. And because I was unsure where everybody was at as far as understanding what is constraint-induced movement therapy, I am going to provide a brief overview of what we know about it based on current evidence and research, and then use some case examples from working with practitioners in Ethiopia and Vietnam. So constraint-induced movement therapy, or CIMT, is an intensive therapy. It's evidence-based, and the actual intervention itself requires that we actually put a constraint on the child's non-affected arm while the child is engaged in high intensity repetition and task practice using the affected arm or the weaker arm. It's typically for children who present with a hemiparesis, so children with cerebral palsy that have a hemiparesis, or it could be for children that have a hemiparesis from having a brain injury, or maybe they've had a brain surgery and it's left one side of the body weak. So they have one strong side, they have one weak side, and we do this intensive burst of therapy to build skill in the weaker arm. What we know about pediatric CIMT has come from the adult models. And the adult models of constraint therapy have been around since the 1970s. And as you can see in this picture, you have an adult that's probably recovering from a stroke. They have one side of the body that is weak. And in this picture, that would be the patient's left arm. And they place a constraint on the patient's right arm, the stronger arm, and they engage them in activities that will build skill in the weaker arm. So everything we know about pediatric CIMT has come from adult models. And again, these adult models give us some information. It's a task-oriented training, and it's used with individuals post-stroke, typically in the adult world. And it's been used to increase function in that paretic upper extremity through what we call massed practice, high repetition practice in shoulder, elbow, wrist, and hand movement. In the adult world, the patient would wear a constraint and engage in up to 6 hours a day of this repetitive task practice and this training with a skilled professional. And this could go on for 14 to 21 days. And it's typically those days are clustered together. So it's not one day a week, it's several days a week over several weeks. So again, the constraint is actually worn in the adult model. It could be worn for up to 90% of the waking day. And the only time it can come off is maybe during bath or shower. And then again, they wear the constraint 90% of the waking day, and then 6 hours a day, they have somebody that's skilled in actually engaging the weaker arm in high repetition practice. And you can see in this picture, somebody is holding like a counter, and sometime in the adult rehabilitation model, they actually look at how many times the patient is using their hand. And some of the studies have noted they can get up to 300 repetitions in an hour in adult CIMT programs. So what we know about constraint-induced movement therapy, it's not what we call forced use. So even though we're putting a constraint on the adult or child's stronger arm, we're engaging them in activities. Forced use is when someone might put a constraint on somebody's stronger arm and just ask them to use their weaker arm without any skill or training, or somebody encouraging them to use their arm in a certain way. So forced use has not been found to be very effective. If you just put a constraint on someone's stronger arm, it doesn't mean they're just going to go out and use their weaker arm. Constraint therapy, though, is this package of treatment. You get the constraint, you have somebody like a skilled practitioner who targets movements with high repetition to build skill. And so it's quite comprehensive, and there's a lot of fidelity into providing this treatment. We know that, again, the adult constraint-induced movement therapy models came from a researcher and a scientist, Dr. Edward Taub. And he really studied this paradigm of how do we get people to use the weaker arm after injury. And he did this by looking at primates or monkeys. And he actually, very interesting studies, if you get a chance to read it, I did provide a really wonderful article from 2012 where he talks about these origins of CIMT. And in these studies with primates, they would take away the sensory sensation of a forelimb of the primate. And when they did that, the primate couldn't feel their arm, and they would stop using their arm, the forelimb. And they would adopt a unilateral or one-sided approach. If they put a constraint on the stronger forelimb, even if they couldn't feel this one forelimb, they would use it. They would use the arm when the constraint was on. And they finally figured out that if you wore the constraint, if the primate had the constraint on the stronger arm, and they used their forelimb that didn't have sensation but had motor function, they used it for up to 21 days. When the constraint came off, the brain had reformed, and the primate now became bimanual again. So there was a recovery they could see from using this intensive paradigm. This is very interesting research. So what do we know about pediatric CIMT? It has been modified from the adult model to make it developmentally friendly, and it's used for children with many different types of unilateral motor weakness, mostly children with hemiplegic CP, which accounts for about just over 30% of all children with cerebral palsy have a hemiparesis type presentation. It's been used with children who have brachial plexus palsies, who have had a hemispherectomy, maybe to help with seizure control or traumatic brain injury. We know that there are over 140 studies, research studies, that have examined the effectiveness of pediatric CIMT and over 30 systematic reviews, and now there's even meta-analysis. So the rigor of research is very, very strong. And again, these studies have used a variety of performance and functional measures. So again, if you look at the science behind constraint therapy, it began with primate models. It really grew into adult models. And then the pediatric models, they really took it forward. So from the late 1980s and 90s, 2000s, the last 3 decades, we've developed new assessment measures that are unique for when you're providing constraint therapy. We looked at fidelity, so we can observe videos and we can assure that the intervention is done with high fidelity. We've looked at the active ingredients, what's in the package that makes it so effective. We've looked at best responders. Who are the children that best respond to this intervention? How much function do they need in their affected hand? We've actually studied models for individuals versus group models, because children like to play in groups. They like to be around peers. So we know that sometimes it can be very effective to apply therapy interventions in group models. So pediatric CIMT happens with individual children and happens in groups. This is a figure from an article that was published by Novak and colleagues in 2020. And it was a consensus panel that looked at interventions for children with cerebral palsy. And it gave them this ranking in order of highly effective to maybe somewhat effective to not effective. And they had it like a green light, yellow light, and red light system. And I just wanted to share this one section because it looked at different interventions that impact the motor performance of children with cerebral palsy. And you can see that CIMT has been found to be highly effective. The bigger the circle in this study means the more published research studies they found. You can also see some of the other published interventions that have been found to be either effective, which would be green, or probably effective for children with CP. So if you have the ability to look at the Novak article, it's an amazing article, especially if you're working with children with cerebral palsy. So we know that in pediatric CIMT, there are these 5 essential components. There's a constraint of the less involved or the stronger upper extremity. You have to provide the intervention with high dosage, and that's beyond typical or customary therapy. The therapy involves encouraging the child with shaping techniques to increase the quality of the movements they're doing. It has to be done with high repetition, not just 5 repetitions, 10 repetitions. We're talking 20, 30, 50 repetitions to get skill in a certain movement pattern: shoulder, elbow, wrist, and hand. And then we know it's important to provide a discharge program. We've given the child a habit of using their weaker arm. Now we want them to continue to do it after the program has ended. So it's important to note with constraint therapy, there's a start to the program and there's an end to the program. And it's packaged over several weeks. And then when the program ends, we want the child to go back and integrate new skills into bimanual function. We also know that a common model used for pediatric CIMT is called the MR3 cycle. We start with the movement that the child is able to do. Movement from the shoulder, the elbow, the wrist, and the hand. We engage them in activities they find fun and engaging, and we reinforce that movement in high repetitions, and then we shape or grade to more mature movement. If the child can only move their shoulder a little bit, maybe after 50 reps, they can move it this much. Maybe after 50 more reps, they can move it this much. And then we continue the cycle. Now maybe we work on elbow movements. So it's very targeted. So I did want to share one video of a child from Vietnam. I've got some other videos. But this one shows kind of where we started. This was his first session, and you'll see what he looks like after 5 days. Now he has a left-sided hemiparesis, and he really has his hand is fisted, and he can't open his hand. And his shoulder is really tight. So we were planning activities to get him to just move his shoulder and elbow. Shoulder, elbow. And you can see how it was so hard for him to move his arm without moving his trunk and his entire body. So we really just wanted him to bat. I didn't expect him to open his hand. I didn't expect him to do a lot except to reach for the target. And again, we did this for an hour and a half, and then we did it 5 consecutive days. So we did it, we placed the objects on the left side of his body, which was the easier side for him because it was the left side that was paretic, and that's what we were working on. And again, really just working on shoulder movements and elbow extension. So I'm going to move it forward a little bit. And this is what he looks like after 5 sessions. I just want you to look at how easy he's moving his shoulder now. And that's just 5 sessions. So you can see he's got a constraint on his stronger right arm, but now he can direct his movement. He can push, and he's not moving as much from the trunk. Now imagine we did this for 3 more weeks and we really targeted shoulder elbow movements. Eventually we would try to work on hand movements too. But we had to start where he was at, and he was really, really tight in his shoulder. One of his goals was that he would be able to help push his arm through a sleeve, like a jacket. And he couldn't do that because his arm and shoulder were so tight. So think about how that movement that we're working on can become functional. So I wanted to move on and talk and give you some examples from the 2 other programs that I've been able to work with some wonderful practitioners to think about how could they use the resources they had available to provide constraint-induced movement therapy. The first project was with a wonderful group of practitioners in Ethiopia, and we were invited by Cure International to come and do a training with their therapist in Addis Ababa, and we ended up training therapists from 5 different hospitals. So the aims of this project were to determine a culturally relevant and feasible model, Ethiopian model, that could retain all those critical elements of pediatric CIMT. We wanted to train the Ethiopian therapists to deliver the therapy with high fidelity, high quality, and then test the efficacy of the model. So we actually helped them develop their own model. So we said, here are the 5 essential elements. Here's what you should try to do. Can we package this in a way that will work for your healthcare system? And again, the training sessions happened in Cure Hospital in Addis. They had a 36-bed hospital. They saw a lot of children with cerebral palsy or musculoskeletal or neurologic conditions. And then again, we trained therapists from 5 other hospitals. Our training sessions were didactic in the morning. And then in the afternoon, we had the therapists bring in children, and we did all hands-on. We tried to do as much hands-on training as possible. And at the end of the day, we tried to review concepts that were unclear. And we really were trying to adhere to cultural practices. So like utensil use. How do children use utensils in this setting, in this culture? What are toys that are commonly used? Because those are the tools that are used for therapy sessions, and that's how we would help the therapist think about how would the child use their arm in a traditional or normal way. Parents were always involved in the sessions because we wanted them to engage in the process. And I'm here with my collaborators, Sharon Ramey and Stephanie DeLuca. We, for the constraint, we really wanted them to consider materials that were common and available in their country. Actually, in this area of Ethiopia, they had a lot of incidents of clubfoot, so they did a lot of casting. So they wanted to use a cast as the constraint, which can be very common in pediatrics. So we talked about, what would be an easy way for you to make a constraint for your child that can be used during your treatment sessions. And the therapist wanted to use a cast constraint. We actually administered a therapist workshop participant survey to look at knowledge. So we were hoping that we improved their knowledge of pediatric CIMT, but also help them develop their own model that was unique and could be delivered in their setting. So we had 12 therapists that were able to fully complete the workshop, but many days we had as many as 17 attendees. So we had people would come in and say, I can't be here every day because I have to work, but I want to be part of some of it. And from our post survey, we found that 100% of the therapists were able to identify all the essential elements. So we felt like that training was successful. 100% were able to identify goals that would be relevant and specific and work well for a constraint therapy program. The only area that was a little low was this understanding of a discharge program. So within their setting, they would see children for these kind of 4-week periods, and then they would send them home. and then they would come back to the hospital for another intensive or another session. But they never sent them home with discharge or home programs. And so we had to really talk about, what does that look like? Should therapy continue when the child goes home? So we decided after that training session, the therapists were like, well, we've developed this new model. We want to enroll children and we want to try our new adapted model. So we did a short pilot research study, and we had therapists who had completed the workshop training and enroll a child and actually deliver the constraint-induced movement therapy model that they had developed. And we had a total of 6 children participate. And here was the model they developed. Again, their constraint could be, a lot of them used a cast, some of them used a mitt. It was worn during the therapy sessions. The therapy sessions were for 4 weeks, and they were 5 days a week, and the child engaged in therapy sessions for up to 2 hours. So sometimes the therapy was just with the therapist, and sometimes the parent and the therapist engaged the child. But the total dosage over 4 weeks was 40 hours. They got 40 hours of intensive therapy, which was much, much higher than what traditionally the child was receiving. And I think an innovation that the therapist came up with that I thought was brilliant was that they had these backpacks for each child. And at the end of the sessions, at the end of the day, they would put toys that were used in the therapy sessions in the backpack, and they would send them home and ask the parents to engage the child in activities that were similar to the ones that were done in the therapy session. So there's this carryover that is beginning. Like, I'm not just doing it in therapy, I'm going to do it at home, which is really critical for children. So I wanted to just share a brief case because I thought it was so interesting. This was one of the children that actually, one of the 6 that went through the whole study. And it was a child who was 1 year, 8 months old and diagnosed with CP and a left-sided hemiparesis. And really presented with tightness in the shoulder, could not move the arm overhead, instability at the shoulder, couldn't weight bear very well. Had poor ability to fully extend the arm, poor grasp and release, and was only using the left hand when requested by parent. So was doing something that we commonly call learned non-use. So they were learning how to be one-handed, and they were learning how to disregard the weaker side. So this was the initial eval. And this was one of our wonderful therapist, Tesfaye, and he was just a brilliant therapist. You can see sometimes the child would put the arm down to weight bear, but you can see that he really tried as much as possible not to use his arm. And he would fully reach across his body to get toys in the left side with his right arm. Like, he would fully reach across his body versus try to use his left arm.
Patty, we have a question in the chat box. Do you mind if I interrupt you for a minute?
Sure.
So Victor has a client who was shot in Uganda about 20 years ago, and he writes that he's unable to use his arm. My first time meeting with him, he supports the arm while put in the pocket all day long because of the weakness. He cannot use the hand to do anything. Can this approach be used in such a scenario where he has taken all of these years because it was 20 years ago? Thank you.
Wow, that's a tough one. I would say the first thing you want is some voluntary use. You want the child or the adult especially to at least be able to move the arm some. I think, again, I've shown you a few videos where the child doesn't have a ton of movement in the arm, but at least you have somewhere to start. You can start with shoulder movement. You can start with elbow movement. Even if he can't grab and hold with the hand, you can still encourage movement in the arm, and then you can build on that movement. So I would have to see his movement to see if there's a way to build on that movement. What we know about disuse is that it affects the brain. So the area that was damaged in the brain, you get cortical shrinkage. You get actually a shrinkage of the area, the white matter around the area that was damaged. Now, how do you change that? It's hard. That area damage is there. It's always going to be there. But you can get cortical enlargement with high intensity therapies. You can get cortical enlargement around the area that was damaged with using neuromodulation. So could it work? Possibly. It would be helpful if he had your patient had sensation too. I think children and adults that have some sensory awareness of their arm tend to do better. They tend to be better responders than adults and children that have abnormal sensation. Yeah.
Thank you.
Sure. So.
Can I say something?
Sure.
Yeah, yes, thank you so much. Now, the scenario is he was shot, gunshot, and then the hand is completely weak. When you try testing for sensations, he has very little, but however, he cannot lift that hand at all. And so what he resorted to doing is put the hand in the pockets in the pants, and that's how he moves. And he does everything when the hand is supported in that way. And it's because of inactivity, I think, it has begun to lose weight. It is thinner, smaller than the other one.
Sure.
And so he cannot lift it at all. So I was wondering whether this approach can be tried with him to see whether it can help. Because I do not know whether due to the gunshot, it is the sensory or the brain that was affected.
Right.
It
sounds like it's sensory and motor. I think your best bet is to not look at what he doesn't have, but look at what he can do. So if he can move the shoulder a little bit, if he can move the elbow, if he's got any movement of the arm, then that's a positive thing. So kind of change and reframe the way you're looking at him. And instead of looking at what he's not doing, look at what he could do, and then ask him to do it more. And that's what constraint therapy is about. While they're wearing the constraint, I'm going to ask them to move their shoulder in the way they can, not 10 times, but 50 times. And then I'm going to ask them to do that every day. And then over time, it's going to change the way the brain accepts that feedback, and it's going to change the way it uses the arm. So I think maybe reframing and observing him in a different way and say, does he have any movements that I can strengthen? That would be probably my first thing I would say. Yeah. So this was this young, oh, you're welcome. This is the young child's first eval, and Tesfaye's like, kind of your question, like, can he do this? Because he really doesn't want to use his arm. And this is what his last session. Okay, so they remember their model was 2 hours a day, 5 days a week for 4 weeks. It was 40 hours of therapy, 1 month. They stuck it out 1 month. This was his last session. I mean, look how beautiful that movement is. His hand's not fisted. He's actively using it.
So Patty, I have another question in the chat from Marion Kenya, and she wants to know, do we have an age limit when using this approach? This is like for an 11-year-old who has hemiparesis since they were born, brought to us at 9 years. Thank you.
Yeah, there is no age limit. We do feel that right now the trials in the US are really for younger children, like infant toddlers, but we know that constraint therapy can be highly effective for children and adults of any age. That neuroplasticity, the brain has the ability to change and to change their habit, the habit of use for that extremity when you give it high intensity therapy. I mean, how beautiful is this? I was so proud of these therapists because they were really able to develop a model that fit within their system, because they typically saw children for 4-week stretches. And then they would send them home, and then the parents would come back. And look how much movement he gained in just 4 weeks, because it was targeted, it was intentional, it was directed therapy, and it was directed at certain movements of the left arm. We did publish on kind of our work in Ethiopia, really talked about, how did we work with these therapists to develop a model that was culturally sensitive, that really was something that could work within their hospitals. And it was published in Occupational Therapy International in 2015. So our next project was on a project that I recently completed in Vietnam. And part of the project included a CIMT component. And this project was involved with humanity and inclusion, which used to be Handicap International. Now they're Humanity and Inclusion. And they received a big grant from USAID to develop and build rehabilitation models in Vietnam. So we were able to do quite a few training sessions with therapists across the country. And in this project, my collaborators, again, were Stephanie DeLuca, who's a scientist at Virginia Tech. And we had Dr. Chi, who was a physician at the Hanoi Rehab Hospital. We had Mr. Tong, who is a PT at Ho Chi Minh Children's Hospital #1. And then Johan Bodewins, who's a PT with Humanity and Inclusion. The CIMT project was funded by a small grant I was able to get from my university's Center for Global Health, and that helped fund some of the equipment and things that we needed for these 2 hospitals. And again, our partners were USAID and Humanity and Inclusion. So what we knew about rehab in Vietnam, we knew that our Vietnamese therapists, very passionate about therapy, wanted to use evidence-based interventions, but there was a lot of inconsistencies on how to apply therapy that was developed in a Western model to their cultural setting, their healthcare setting, because it's very different. There was minimal literature on how pediatric CIMT could be applied in low and middle income countries. And there was no research on, this was very new to them, constraint therapy in Vietnam. And so we knew that international CIM literature had not examined if protocols or programs were adhering to these essential principles of constraint therapy. So we knew there were some gaps. So again, through this funding, we knew that the Vietnamese therapists wanted to do evidence-based interventions like constraint therapy, but it was unclear how they could do it. So we could train them, but we weren't sure, you can train somebody and you can educate them on a model, but how do they really deliver it in their own setting, within their own rehab setting, within their own hospital setting, to their families and children? So within the context of the Vietnamese healthcare system and the potential limitations and barriers. So our aims were to determine if these 2 models, the Hanoi Hospital and the one in Ho Chi Minh City, each developed their own models of constraint therapy that would adhere to the 5 essential elements, but fit within their healthcare system. And then we wanted to determine if these models could improve the function of children with hemiparesis. So those were our 2 aims. And again, our participants were children with hemiparesis, and they were ages 18 months to 7 years. So it was a wide age range. And they were recruited by the therapist in the Hanoi Rehab Hospital over here, and then Ho Chi Minh City Children's Hospital #1. And I'm just going to tell you a little bit about their models. This was the model that was developed in the Ho Chi Minh City. They wanted to do a high dosage model. They felt like they could do this. They had the therapist. So they did 1 hour. They did 6 weeks, 7 days a week. 1 hour with therapist every day, and 1 hour with family for 5 days a week. And on the weekends, the families did an additional hour. And the constraint was a resting hand splint covered with an ACE wrap. So they did 12 hours a week times 6 weeks. So they got up to 72 hours in 6 weeks. That's a lot of therapy, high dosage. Imagine doing high intensity therapy and how that's sending really targeted information to the brain, how it's going to change the brain, which is going to change movement. The Hanoi hospital, they provided, this was their model, 4 weeks, 5 days a week. They did an hour and a half every day, only 30 minutes with the therapist, but then the parents continued the constraint therapy session for another hour. So the parents were trained to actually do more of the therapy. That was their model. The constraint was a resting hand splint with a mitt covering the splint, and you can see that in this picture. So they did 7.5 hours a week times 4 weeks, which was 30 hours. We used different outcome measures. We used a Fidelity of implementation tool that was developed by Stephanie DeLuca for a US study. And what we did is we had the therapist videotape their therapy sessions, and we would watch the therapy sessions and we would rate them to make sure they were maintaining the fidelity or the integrity of doing constraint therapy. We also used some capacity tests. The therapists used the Able Hand Kids, the Pediatric Motor Activity Log, and the Box and Blocks at baseline, right before CIMT started, and right after CIMT. We also used something called the Goal Attainment Scale, which the therapist and the parents set individual goals for the child. I want my child to be able to take their shirt off. I want my child to be able to hold a spoon. So they set individual goals for all the children. And again, we analyzed the data. We did a video analysis. We had 2 or more raters watch each of the videos. We did a repeated measures ANOVA for analysis over the 3 time points for the capacity measures. And then we converted the GAS to T-scores that have a mean of 50 and a standard deviation of 10. So here's some demographic information. In the Hanoi group, we had 10 children. The age range was 22 months to about 6 years, which was about 3.5 years mean age. We had mostly children with right hemiparesis, but we had some children with left, pretty even between males and females. And then we looked at the gross motor functional classification scale and the manual ability classification scale, which are 2 scales used for children with CP. And we actually had some children that didn't have very good hand function to start. The levels for the max go from a level 1, which is really good hand function, to level 5, which is poor hand function. And half of the children had a level 4. So I was worried, like, how much are we going to be able to do here? But you'll see. Ho Chi Minh City, they had 10 children, average age 4.6. It was surprising. They had all children with right-sided hemiparesis. And they had children that were mostly ambulatory, that walked well, and their hand function was a bit higher at the start.
Patty, we have a couple questions, if you don't mind. And
sure.
The interruption, sorry. The first question was, can CIMT be used for children with poor coordination, athetoid CP? How diverse is the intervention? Let's say are 2 hours spent moving objects or hitting targets. And then the second one was, are these assessments cross-culturally valid for the Vietnamese pediatric populations?
I'm really glad you asked that question. So the first one is, yes, it could be used for children with athetoid type CP. But remember, you're really looking at children that have one side that is weaker than the other side. So sometimes we know children with athetoid type CP can have spasticity, and they can also have motor issues outside of the athetosis. So if they have one side that is weaker, then this could be beneficial. Just for athetosis, I would say it's probably not the intervention for you, because athetosis is a whole different type of movement disorder, and there may be a better intervention. During the activity, it's 2 hours, but it's fun and playful. You are targeting shoulder movement, but they're doing things to push and move and brace and put their weight in their arm, and maybe brushing their arm or putting their arm into a sensory bin or water. So you're engaging them in activities that are repetitive, but fun. Like, children are not going to be engaged for 2 hours by just telling them to do something. We all know that, right? So you have to be creative. and innovative in your activities. And these therapists were. They came up with some of the best activities I've ever seen. Culturally sensitive. Before the study, we had to actually validate. We validated the able hand kids, and we have a paper that's coming out for the Vietnamese version of the able hand kids. And we had to actually validate the pediatric motor activity log, because I don't think it's, especially when you're using like real world parent questionnaires and they're about activities that are done in real world settings, I think they have to be culturally sensitive to be relevant. So we, even before we did the study, we had to validate both of these assessments. And we also validated the Pediatric Evaluation of Disability Inventory. Fidelity. Fidelity was how closely did these therapists adhere to the principles of constraint therapy? So the fidelity measure was a 4-point scale. 1 was does not meet fidelity. 2 was meets fidelity. 3 was high fidelity. And 4 was very high fidelity, no errors. Both groups were between meets to high fidelity, which was as good as the US therapists that are doing research intervention studies right now. So I thought that was pretty incredible. And this, again, these videotapes were watched by 3 different raters, and then we averaged the ratings. So the GAS results. Remember the mean for a GAS group score is 50. So each of them were over, these children were met or exceeded goals. 100% of the children in the Hanoi group met at least one goal, and 90% in the Ho Chi Minh City met at least one goal or more. So here's a video. This is a young child. Here's his pre-video. He's got a left-sided hemiparesis, and his goal is being able to use 2 hands to take his shirt off. And here is his pre-video. So you can see he's struggling. He can't do it. And then remember, this was the group that did the lower dosage CIMT 30 hours, 30 minutes with therapist, 1 hour with parent, 5 days a week times 4 weeks. Here we go. Here's his post. That's pretty incredible. And I mean, there's all these videos we took from these 20 children. Most of them look like this, like holding a cup with 2 hands. In Vietnam, they hold their bowl with the one hand while they're using chopsticks with the other. So holding the bowl was a really big goal for a lot of kids, being able to hold it without turning it and without dropping it. And they were able to do this after this 1-month intervention. This is a figure that shows the significant improvement in the able hand kids pre and post CIMT. So you have baseline, you have pre-CIMT, and you have post-CIMT. And in green is the Hanoi group, and in blue is the Ho Chi Minh City group. And you can see from baseline to CIMT, their scores on the able hand kids were not changing very much. But after their CIMT program, you can see a statistically significant change in the able hand kids. So baseline didn't change, but after CIMT, it did. This was the pediatric motor activity log. And they have sections for how often does the child use their hand and how well do they use their hand. The Hanoi group is in blue and green. The Ho Chi Minh City group is in red and gray. So you can see at baseline to pre-CIMT, we actually had some children in the Hanoi group, actually their scores went down and how well they use their hand. But then after the CIMT program, you can see the nice increase that was statistically significant for both how well and how often they were using their affected hand in those everyday activities. The box and blocks is a measure we use sometimes to look at grasp and release. And if you're not familiar with it, it's this wooden box. It's not very exciting. And the children or the adult is asked to pick up one block with their hand, lift it over this partition and drop it. And they have a minute, and you count the number of blocks that they do. The children in the Ho Chi Minh City group showed a statistically significant change. Both of them showed a change after CIMT, but there was a statistically significant change in the Ho Chi Minh City group with this specific test of grasp and release. So in summary, with this initiative, we were able to help 2 clinicians in 2 pediatric hospitals in Vietnam really develop their own unique CIMT programs that adhered to the 5 core principles, and they were able to deliver it with acceptable fidelity. So we had children in both a lower dosage and higher dosage CIMT program show significant gains. And these results were very similar to pediatric CIMT studies in the US, which we thought was very impressive. It was the first study to really examine implementing high quality CIMT using these newly validated outcome measures. Like I said, we did have to validate measures before we did the study. And we hope that it helped the therapist really think about evidence-based practice. How can you apply it? How can you apply models that were developed in other countries and deliver them in the country that you're in? And we know that the therapists who completed the study continue to use CIMT, and now they're training others. And that makes me a little sad because I don't get to go to Vietnam anymore, but it's really exciting to know that, you know, you have empowered them to be the experts within their country to train other people on their models, which is great. And that's our group of exciting therapists, which was great. And so my final thoughts, I think adapted or modified constraint therapy programs can be designed and implemented for different settings where resources may be limited or varied from what we see in the US. It's important that you consider how do you maintain the essential elements of pediatric CIMT or any rehab model. You know, what are the things, what are the active ingredients? What makes that therapy special? Maintain those active elements and then modify it based on the resources you have available. I think it's important to do kind of a thorough cultural review. In pediatrics, we use toys a lot. In Ethiopia, some of the assessments that we brought over were not culturally relevant and we didn't use them. You know, kids were scared of them. They didn't want to participate. So it made me realize that, you know, you have to do a really nice scan to make sure that you're consistent with what's going on within that setting. Consider how you use communication. It's much easier now with Zoom and Skype and all sorts of WhatsApp, but consider communication. With Vietnam, we had weekly sessions and they were 12-hour difference. So I would, you know, have sessions at 10 p.m. at night or 9 p.m. at night, and they would be, you know, early in their morning. So we had to figure all that out. Consider long-term planning for partnerships. Certainly we want to support our collaborators after we've done our sessions. So empowering them to move forward and continue to collaborate. And these are my references. And that's it.
Thank you so much, Patty. I didn't want to interrupt, but we had a few questions there while you're going over your last slides. So with pediatric CIMT, casts are used during therapy sessions only or maybe advised at home too? And then the second question was, are there specific materials you use when making the constraint?
Yes.
To those, and then there's one more.
Okay. So the first question, you can. I think it's important that if you do, the constraint many times is worn during the therapy session for children. And for children, if you want them to go home and wear the constraint, just make sure there's an activity planned. Remember, constraint therapy is not forced use. So many times with children, if you just have them wear a constraint and you expect them to use their weaker arm, they'll just do nothing. They're just stubborn, you know? So sometimes, again, if you want them to do an activity at home, you should train the parent and say, you know, the child should wear the constraint, and while the constraint is on, here are 5 different activities I want to see them do. So there should be still a plan for what the arm is and hand is going to do when the constraint is on. Constraints. My rule about constraints is it has to be comfortable. It can't be binding. So for instance, I don't like constraints that the arm is tied to the body, because if the child falls, they don't have a protective response. But if they have a mitt on or even a cast on, they can still have a protective response. So it has to be comfortable for a child. It can't cause, you know, pain. So keep that in the back of your mind. The constraint has to take away their ability to use their hand in the stronger side. So if you just put them in a sling and the hand is still open, it's not really shutting down that side of the body. So keep that in the back of your mind too.
So another question, I am asking if there is any adaptation to the CIMT for children who are not able to withstand the constrained hand for such a time of 1 hour or 2 hours.
That's a toughie. So I've been doing this for about 20 some years now. And I've never met a child that I could not figure out a way to encourage them to wear the constraint, even for an hour. It's the planning of the activities. It's starting where their movement is. Most children don't wear the constraint because you've put something in front of them that is much too hard to do and they get frustrated. So sometimes I just start with a bucket of water and water play. And, you know, now they've worn the constraint for 30 minutes and we're just playing in water. I think I showed that in the one video. You have to start where the child has potential movement. For the child in Vietnam that I showed, if I would have asked him to grab something or to open his hand, he would have got really frustrated and started crying and not worn the constraint. But I got him engaged in activities where he didn't think about wearing the constraint. And then after a while, it just becomes a habit. Child walks in, put the constraint on, start engaging in activities. So I think the trick is looking at what is the least they can do. What is the least I should expect them to do? Just move the shoulder, push something down, knock it over, play in water. And then you can build skill over time. Constraint therapy is a starting point that builds skill over high repetition. It's not where you end, it's where you start.
So we have some more. How long should CIMT be used? And is the cast removed after the session?
Many times the cast is removed after the session. And so what we do in the US is we univalve it or bivalve it like a clamshell, and the cast goes on and it's strapped, and then the cast comes off at the end of the session. It can be left on. And some programs, they leave the cast on. But again, I think the constraint therapy treatment is while the cast is being worn, they're engaged in high repetition activities, intense therapy, massed practice. So the cast can stay on. You just have to watch their skin. Like I wouldn't, if you have a cast on the child's stronger arm, I wouldn't leave it on for more than a couple days without removing it to check the skin. Just be really careful about that.
Okay. Is the method effective in children with attention difficulties? And then how exactly is CIMT used to improve weight-bearing protective response, weight-bearing and / protective responses?
Yeah. So children that have attention or cognitive issues can be a little tricky. I think you've got to plan for that. I think the child in the video I showed from Vietnam had some attention issues. So we had a lot of different activities, and we might start with one, do that activity for about a couple minutes, then go to another one, and then come back to the first activity. So it's like a round robin. So you just have to plan, you really have to plan your sessions for a child that has limited attention. I also feel like children that may have limited attention, I always look at vision and sensation. So are they not attentive because they don't feel their hand, or they're visually not very responsive to that side? So I would check all that out before you would start. So it's not always cognition and attention. Sometimes I think it's sensory too.
Okay, Victor in Uganda asks, I beg your pardon on the materials. Did you say there are specific materials used? If yes, what are the materials? Does it have to bear some weight?
No, the materials can vary. You know, you can use cast material like plaster of Paris, but again, I wouldn't keep that on for more than a couple days. You'll have to cut it off. You can use a mitt. You know, anything that can cover the hand can be used as a constraint. I've had therapists use, you know, ACE wrap, and they've wrapped the arm to take away the ability for the child to use their hand. So you want to take away the sense that they can use their hand. You do want them to be able to put their arm out to protect themselves if they fall. But if you take away their ability to use your hand, I've had therapists use socks, but they've kind of stuffed the sock and they've strapped it on. That happens a lot in different countries. Again, if you make it like a pillow, some of those beginning pictures where I showed they use a mitt that looks kind of like a pillow. It's soft, it's comfortable, but they just can't use their stronger hand anymore. So they're forced to use their weaker hand while you engage them in activities. Weight bearing. I think there was a question about weight bearing. Absolutely. I think you can put children, when they're wearing the constraint, you can put them in crawling positions. You can put them in different weight bearing positions. Weight bearing, remember, requires, you can weight bear through the elbow, but you still have to have co-contraction in the shoulder and some strength. Weight bearing through the arm requires elbow extension. So maybe you work on range of motion, get full elbow extension, and then work on weight bearing. So I think there's a progression, and that's why we call it shaping. It's not where you end, it's where you start. It's the steps to get there.
Jean-Claude, did you have a question?
Thank you very much for this wonderful presentation.
Well, you're welcome.
Okay. You say there's someone asked the question about the age limit for the use of this CIMT Pediatrics. And the response was there is no age limit. I would like to ask this because, especially when I take an example on treating with the cerebral palsy. So first, I don't know if there is maybe any study conducted to see the percentage of children with the cerebral palsy that can fit with this CIMT. The reason why I'm asking this is that, for sure, from on my side, I think 80% of the pediatric cases I've seen with CP, 2 or 5 of them, they can fit with this CIMT. For number you said, in age range, child can be fit with this CIMT. Take an example, child is having maybe 4 or 5 months, or this child is still struggling with what about brain mobility. So if you apply this CIMT to this child, will it really work, or it will limit again the other was not function for this child?
So you're asking if it's like an infant that's 4 or 5 months old? Yeah. So we haven't looked at children any younger than 6 months, just because in the US they typically don't show that asymmetry, that inability to use only one side of the body very early. It usually happens around 6 months when they have difficulty rolling and sitting up. So I would say 6 months is the earliest. And right now, I would say 6 months, 7 months. There are research studies, case series. I've done a case study that was published where it's been highly effective in infants. And we did 1 hour a day for 30 consecutive days. So our dosage was 30 hours, 1 hour a day with a soft constraint where we engage them in activities with the weaker arm. And we did that for 30 consecutive days, and it was significant. So I don't know about 4 months. I think that's a little young, but I think over 6 months, you're probably good to go. And older children, most of the early studies have been done with adolescents, teenagers, and then they started going down in age. And now most of the current studies now are with infants and toddlers.
I think again, I would like to know if there is maybe any published study showing the prevalence of children with cerebral palsy. How was the percentage from those children with cerebral palsy that can benefit from this CIMT? The reason why I'm asking this is this. If we took an example for a child with cerebral palsy, be it atetoid, be it spastic, I think to find a CP child with hemiplegia or hemiparesis.
Jean-Claude, can you, I'm sorry, if you have a lot of noise in the background, could you possibly type the question in? I'm not sure what's happening, but we're getting a lot of static in the
It's a
background.
lot of feedback.
Yeah, I'm not
You
sure.
know, Jean-Claude, I know what you're saying. I would say from what we know from the percentages of children with CP, it's about 32 to 33% of children that are diagnosed with CP have a hemiparesis. So about a third have a hemiparesis, and that's a spastic hemiparesis. So they don't have athetosis and hemiparesis. So it's not this. I don't know if this therapy is effective for children with ataxia or strictly athetosis. It's really highly effective for children with hemiparesis or one-sided motor weakness. Highly effective. And most of the studies out of the over 140 that have been published, I would say 90% of them has been with children with CP. Most of them. In utero, stroke, that, you know, some type of injury at birth.
We have 2 last questions, and then I promise I will let you go. So the
Okay.
last 2 questions are, I would like to know about hybrid CIMT in children, if it should be used in compared to CIMT alone. And then the last question, can it be used in Erb's palsy?
Yeah, so yes, it can be used in Erb's palsy. There's a couple published studies out there right now that shows that it is very effective to get, if you think about brachial plexus palsy, there's likely a sensory component and they're not attentive to that side. So if you can get them to, if they can move their arm, you can strengthen a movement. That's the basis of rehab, right? If you have a movement in the shoulder, the elbow, the wrist, and the hand, you can strengthen that movement with high repetition. So very effective in CIMT for brachial plexus palsy. So the other question is hybrid. I would say, again, those 5 essential elements. Have to have a constraint, has to be done with high dosage. Again, the minimum dosage that we found to be effective is 30 hours, probably packaged over 4 to 5 weeks. So high dosage, getting therapy every day, an hour or more a day. You should shape, you should start where the movement is, and you should build repetition, high repetition over time. And then you have to have this discharge package. Once they've gained a habit of using their arm, you need to give them activities to do after the sessions are over. What can they do with that new movement now? So you have to have those 5 essential elements, but each of the models I showed you were adapted, and some had the parent doing more, some had the therapist doing more. I think it can be adapted as long as you keep the 5 elements.
Well, thank you so much. And I just wrote in the chat box that any further questions, I will email you, and then I will email to the group because I want to be respectful of your time. And I appreciate you coming so much. This was wonderful.
Well, it's been a real pleasure to be here. Good luck with all you're doing. It's exciting to see so many wonderful practitioners across the world join in. So thank you.